It's my great pleasure to introduce Dr. Julie Gralow. Dr. Gralow got her undergraduate degree from Stanford University and her medical degree at UCLA before continuing her internship and residency at the Brigham and Women's Hospital. She came to the University of Washington for her oncology fellowship. She was promoted to full professor in the Division of Oncology in 2009 and in the Department of Global Health in 2011. She also holds positions in the Ellison Center for Russian, Eastern European, and Central Asian Studies, the Henry M. Jackson School of International Studies, and is the Jill Benet Endowed Professor in breast cancer. She has multiple awards and honors, including Seattle's Business Magazine's Leader in Healthcare Achievement and Community Outreach Award last year. She is the member, director, and editor of a number of societies and journals, and her list of publications around the intricacies of breast cancer diagnosis and management is quite extensive. On a personal note, I've had the great pleasure of working with Dr. Gralow. She's one of our tremendous teaching faculty and a great mentor for many of us who are interested in pursuing careers in oncology. So, with great pleasure, please let me introduce Dr. Julie Gralow.
Great. Thank you so much for that, and good morning, everyone. I'm going to speak today on strategies for breast cancer risk reduction, trying to think of a topic relating to breast cancer, but that would have implications for those of you in internal medicine, primary care, anybody who's seeing women who would be asking you about breast cancer risk and screening. My disclosures: I receive research funding from Roche Genentech, Novartis, and Amgen. The outline for today's talk will be: first, I'm going to overview breast cancer risk factors, because you can't really advise your patients on risk reduction unless you can help advise them on what their risk is. I'll briefly go over a couple of breast cancer risk prediction models or tools that you can use. Then I'll get into primary prevention, reducing the risk of breast cancer incidence, and then secondary prevention, which would be screening and early detection, so finding the cancer early to reduce morbidity and mortality. Just to orient us all, these are the leading cancers in U.S. women as of last year per the American Cancer Society. These are really estimates because it takes several years to clean up the data on how many cases were really diagnosed and how many deaths occur. You can see breast cancer is the most common cancer in U.S. women after skin cancers, non-melanoma skin cancers. These are just invasive breast cancers, and yet lung cancer beats breast cancer in terms of numbers of death. And there's a big gap between the incidence in red and the deaths in yellow for breast cancer. Rounding out the list of the top cancers in U.S. women are lung cancer, colorectal, uterine, ovarian, lymphoma, and melanoma. And for those of you who do rotations on our oncology service, you would probably guess it was leukemia, because that's what you're spending most of your time taking care of, but that's just an inpatient kind of disease. We do most of breast cancer in the outpatient setting, and we'd be happy to have you join us in our outpatient breast cancer clinic if you want to do a rotation there. Globally, breast cancer is the most common cancer in females, and this map shows which is the most common female cancer in various countries. The pink is breast cancer, the red is cervical cancer. So you see that in parts of the world, cervical cancer still has a higher incidence than breast cancer, particularly sub-Saharan Africa, parts of South America and India. Although in those countries, breast cancer is generally increasing, and cervical cancer, hopefully with the HPV vaccine and all, will be decreasing. So what about breast cancer risk factors? The two biggest risk factors for breast cancer are being female and getting older. So we can't really reduce that risk by much. The next biggest risk factor is hormone and reproductive factors, and one way to think about it is the number of menstrual cycles you have in your life. The more menstrual cycles, the higher your risk. Next is family history and genetics, and this is a very important risk factor for a minority of women. Okay, so that is not common, but in a subset of women, that is their biggest risk factor. Lifestyle can contribute. I'll talk about that. Environment, hard to say exactly what our exposures in our environment with respect to background radiation and pesticides, how much they contribute, but they do contribute. Radiation therapy to the chest at a young age, so a young woman in her late teens, early 20s who gets mantle radiation for Hodgkin's disease has about the same risk of developing breast cancer as a BRCA1 or 2 gene mutation carrier. Mammographically dense breasts is a newly diagnosed risk factor. I'm going to spend a little bit of time later talking about that. If a woman has had a biopsy of the breast for any reason and that biopsy came back with atypia or hyperplasia, she is at increased risk of future development of breast cancer anywhere in either breast, not necessarily the spot where the biopsy was. Whatever led to the atypia and hyperplasia also exposed all the tissue in both breasts. And then a personal history of breast cancer. If a woman has already had one breast cancer and she has remaining breast tissue, her risk of a second breast cancer is higher than an average woman's risk of a first breast cancer. So let's talk just a little bit about hormone and reproductive factors. Again, I said the number of menstrual cycles you have in your life is predictive of your breast cancer risk. If you look at age at menarche and you compare a high-risk group of starting to menstruate below the age of 12 with a low-risk group of greater than 15 versus a high-risk group of less than 12, the relative risk is 1.3. So a 30% increased risk of breast cancer if you started menstruating below 12. Age at menopause, the high-risk group is continuing to menstruate till 55 or greater. Lower-risk group is stopping menstruation at 45 or less. And the relative risk between those two groups is twofold. Age at first live birth. So the younger you are at your first live birth, the lower your risk of breast cancer. Something about going through the terminal ductal differentiation of creating milk at a young age is protective. The more pregnancies you have, the more protective with respect to breast cancer risk. Menopausal hormone therapy, at least combination therapy with estrogen and progestin compared to placebo, has a relative risk of 1.26, so a 26% increased risk. And then breastfeeding, during pregnancy and during breastfeeding, you have estrogen and progesterone, lots of hormones around, but they are more constant. They're not the ups and downs each month. And so by lactating, you're generally suppressing the menstrual cycle. And we have seen in multiple observational studies that you have a relative risk decrease of 4.3% of getting breast cancer for every 12 months of breastfeeding. With respect to menopausal hormone therapy, the big Women's Health Initiative, which was coordinated out of the Fred Hutchinson here in Seattle, was really the first and main study to do a randomized clinical trial of menopausal hormone therapy or placebo. It also was a huge trial enrolling menopausal women, many of whom didn't go on the primary randomized study, but they could also look at diet and calcium and vitamin D and a lot of other factors in menopausal women. So there were 40 U.S. centers that participated. There were two main studies I want to discuss that were very similar, but one was for women with a uterus and one for women without a uterus. So the combined hormone therapy study enrolled 16,000 postmenopausal women, and they were randomized to conjugated equine estrogens and medroxyprogesterone orally daily versus placebo. And then if you didn't have a uterus, you didn't need the progesterone, so you just got the 0.625 milligrams of conjugated equine estrogens. The first of those two studies to report was the study for the women with the uterus, which was the combined hormone therapy. And this slide shows, as it was published in 2002, the excess risk of various conditions per 10,000 person years. So they had aimed to have women on this hormone therapy for about 8 years, was what the study had proposed. I'll first point out that in both of these studies, the average age of enrollment was 63. So just take that into account when you're counseling your women in their late 40s and early 50s who are having horrible hot flashes and night sweats and can't sleep. That's not who was enrolled in this study. They were a lot older, so they had different risks for cardiac disease, fractures, etc. So the results were that there were 7 extra cardiac events per 10,000 person years, which resulted in a 29% increase. All of the prior observational epidemiologic studies that led to this study had suggested that actually cardiac events are decreased for women taking hormone therapy. And so this randomized study showed the opposite. There are probably things about women who chose in an observational study to go on hormones that also led to less cardiac risk. Breast cancer, there were 8 more events per 10,000 person years, which was a 26% increase. These are both accurate ways of looking at the statistics. You're looking at absolute risk and relative risk. So guess what made the front page of all the newspapers? 26% increase in breast cancer. But then you think about 8 extra breast cancers per 10,000 person years, and you're counseling your patient, and that sounds very different, even though it's the same exact data. Strokes and pulmonary emboli were increased. There's a little bit of increased thromboembolic events. Colon cancer was decreased. We had actually seen that in the observational studies. Uterine cancer, there was no difference because of the addition of the progesterone. Hip fractures were decreased. Estrogen is good for the bones. And there was no difference in deaths. Now, just a couple years later, we saw the reporting of the estrogen-only study for the women without a uterus. And now we saw 5 less cardiac events that was just bordering on statistical significance, and 7 less breast cancer events, again, just bordering on statistical significance. So that was fascinating, that maybe it was the progestin that was the culprit in this. There were more strokes and pulmonary emboli. There was no difference in colon cancer. Maybe that's also a progesterone effect. These women didn't have a uterus, so there was no difference in uterine cancer. There were still less hip fractures. That is an estrogen effect, and there was no difference in death. So the question was, at least with respect to breast cancer, is progesterone the culprit? And remember, this study gave continuous daily oral medroxyprogesterone. We have other ways we can give a little bit of progesterone. We can slough the uterine lining periodically. We don't need to give it continuously, but we don't have evidence on other ways of giving progesterone. So what happened was as soon as the first trial was reported at a meeting before it was published, prescriptions for postmenopausal hormone therapy dropped dramatically by about 35 million prescriptions per year between 2000 and 2004. Huge drop in the prescription of postmenopausal hormones. And interestingly, if you look at the breast cancers diagnosed in that same time period, you had a decrease of about 1% per year kind of going into that time period, and then a 7% decrease in 2003 in a single year in breast cancers diagnosed in this country. And then it kind of leveled off again here. So fascinating to think that we could have such a drop in diagnosed breast cancer. Some of them were undoubtedly just delayed and pushed out farther, and others may have been prevented entirely. So what about oral contraceptives or taking hormones when you're still premenopausal for contraceptive purposes? I'm just giving you the data from the National Cancer Institute summary. You can go and find all the evidence of all of the trials. There are no randomized trials of oral contraceptives versus placebos. But the US NCI says that the results of studies evaluating oral contraceptive use and cancer risk is not consistent. There's some data suggesting that current use of oral contraceptives appears to slightly increase the risk of breast cancer in a few studies, but that risk is back to normal 10 years after you stop taking the oral contraceptives. Oral contraceptives are associated with decreased ovarian and endometrial cancer diagnoses, and that decrease in ovarian and uterine cancer increases with the length of time you are on the oral contraceptives. And oral contraceptives are associated with increased cervical cancer, but that's likely confounded by increased HPV in those women. So that's hormonal therapy risk, and briefly let's review genetic risk of breast cancer. I told you that this is a very important risk factor for a minority of women. So what you see in this pie graph is that the majority of breast cancer is really felt to be sporadic. There's no strong family history. Hereditary breast cancer, meaning a real strong genetic trend, it probably accounts for about 5 to 10% of breast cancers diagnosed. And then there are family clusters, which are about another 15 to 20%, which might be weaker genes or kind of more societal, cultural kinds of things that run in families or similar exposures. So most women diagnosed with breast cancer don't have a strong family history of disease. So when you're counseling your patient and you do the family history and there's no family member, that doesn't mean that her risk is low because most women don't have a first-degree relative with breast cancer. So what are the breast cancer susceptibility genes as we understand them in 2015? There are high penetrance genes, meaning if you have a mutation or an abnormality in that gene, you're highly likely to get the cancer. And then there are more low and moderate penetrance genes. So BRCA1, which stands for breast cancer gene 1, and BRCA2 account for the majority of what we understand now as inherited breast cancer. P53, associated with Li-Fraumeni syndrome, has excess breast cancers, as well as, at a young age, excess brain tumors, sarcomas, etc. P10 is another gene with a higher penetrance. That's associated with a hamartoma or a Cowden syndrome. That is a rare cause of breast cancer, increased risk. Peutz-Jeghers syndrome, which we think of more as being associated with increased risk for GI cancers, also has an increased breast cancer risk. I have a couple of those patients in my panel. And then CDH1 is associated with a syndrome that we call diffuse gastric and lobular breast cancer syndrome. That's quite rare. The lower and moderate penetrance genes associated with breast cancer susceptibility are CHEK2, PALB2, which is a recently recognized gene, just been written up in the last 6 months, BRIP1, RAD51, and ATM. So let's talk a second about BRCA1 and 2, since they account for the majority of inherited breast cancers. They are tumor suppressor genes associated with DNA repair, as are a lot of those other genes on the prior slide as well. So if you inherit a non-functional copy of either BRCA1 or BRCA2 in every cell in your body, you're already one mutation or mistake on the way to developing breast cancer or ovarian cancer in every cell in your body. These genes are inherited in an autosomal dominant fashion, so the father's side of the family is just as important as the mother's side. And I've told you these are very high penetrance genes. If you inherit an abnormality in BRCA1 or 2 associated with malignancy, then your breast cancer lifetime risk is 50 to 85%. Your ovarian cancer lifetime risk is 15 to 40% higher in BRCA1. These cancers are early onset. Half of these cancers, breast cancers, are diagnosed by age 41. The average age of diagnosis of breast cancer in the U.S. is 62. So this is 20 years younger than sporadic breast cancer. If you have a breast cancer develop and you leave your other breast, then you have a 40 to 60% chance of developing a second breast cancer. Male breast cancer risk is elevated. We quote about a 6% rate of male breast cancer, more common in BRCA2. That doesn't sound very high, but it's markedly higher than an average male's risk of breast cancer, which is well less than 0.1%. And then other cancers are slightly elevated: prostate, pancreas, fallopian tube, and other cancers, but to a minor degree. We can do genetic testing for BRCA1 and 2. We've been able to do this since the mid to late 90s. And the benefits of this would be that you can identify high-risk individuals in a family, and you can identify lower or average-risk individuals in a family if you can find a mutation and then track it. It allows prevention and early detection strategies, and it may relieve anxiety. Even knowing that you have the gene or not knowing, either way, it can help with that unknown. The risks are that current testing for BRCA1 and 2 doesn't detect all mutations. So if you get a negative result, it doesn't mean you don't have some gene running in your family. It just means we haven't found it. There's a continued risk of sporadic cancer. The average American risk of breast cancer, if she lives out to be in her 80s is about 12%. The exact efficacy of some of our prevention interventions is unknown, and it's expensive. Insurance is increasingly covering it, but if you have to pay out of pocket, a standard BRCA test costs about $3,500, although that's coming down now with competition. Here's a family history plotted out. Here's the generation that came in for genetic testing, with one sister who had breast cancer at 47, a mother who died of ovarian cancer, a grandmother who died of breast cancer at a young age, 33, and a maternal great aunt with breast cancer at 35 and then ovarian cancer at 60. So we were able to find a mutation in BRCA1 in this woman and then offer testing to her siblings, of which one sister had the mutation but hadn't yet developed cancer. Another sister didn't develop the mutation, and a brother developed the mutation, which I've said gives him a slightly increased risk of cancer, but actually it's more important to his daughters. Dr. Mary Claire King, who's here at the University of Washington, actually, while she was at Berkeley, collected families, and her career led to the discovery of BRCA1 and 2. And I put this slide in for fun. There's actually a movie that played, I think it was last year at the Seattle International Film Festival, called Decoding Annie Parker, that talks about a real woman in Canada who was diagnosed after her mother and sister died of cancer. And she's kind of leading up in Canada that she knows there's something in her genes. And then Helen Hunt plays Mary Claire King, working in Berkeley, trying to find the gene. And with her NIH, grants people saying, you're crazy. Cancer's not inherited. And so actually, Mary Claire she is portrayed very well in this as being a pioneer. So where is Mary Claire gone and her group gone? Well, we now have at the UW a test that Mary Claire and her colleagues have developed called the BRCA test. Mary Claire wanted to call BRCA1 BRCA1 for breast and ovarian. She was overruled. So now she calls her new test that looks at currently about 40 cancer-associated genes, BRCA, and she kind of named it after Paul Broca, who was a father of human genetics, but she got that O in for ovarian too. So we can order BRCA now here. And actually, since the June 2013 Supreme Court decision that actually said that Myriad Genetics could not own the patent to a normal human gene, Mary Claire can actually add BRCA1 and 2 into the panel of BRCA. So BRCA focuses on families that include breast or ovarian cancer, and depending on the gene, it can actually predict risk for some other cancer types. It is next-gen sequencing. It's looking at about 40 cancer-associated genes. Some are more experimental, so you're going to get a lot of variants of unknown significance where they're a little different. You're not quite sure if that's a malignant expression or not, but some of them are quite validated. Turnaround time's about 8 weeks, and if you have to pay out of pocket, it costs $3,800. My finding is that if the patient hasn't already had BRCA1 and 2 testing, and she has a good reason, a good family history reason, more insurance companies are paying for this as the primary way to do BRCA1 and 2 and then get the extra genes. So here's just one abstract. It's only been presented at a meeting. I haven't seen it published yet, but it's looking at BRCA in high-risk families. Tom Walsh here from our lab medicine group presented this at a meeting in 2013. So they took some of these families that Mary Claire's group had collected over time that were negative for BRCA1 or 2, but that they had at least 3 family members with breast or ovarian cancer, and at least one person in that family with cancer had tested negative by conventional testing for BRCA1 and 2. And they ran a BRCA assay on that. It was an earlier form of BRCA, so I think it only had about 18 genes. And they actually found a mutation that tracked with the cancer in 26% of these 700-some families. Now, interestingly, 35% of those, or 66 families, they actually were BRCA1 and 2 associated, that were found by next-gen sequencing and not by kind of older generation sequencing by Myriad. So that's interesting. And then 125 of them, or 65% that they resolved, were other genes associated with breast cancer, such as CHEK2, PALB2, ATM, and others. So still, about 3/4 of the families they weren't resolved in. So we have some other genes to find. Now, quickly, breast cancer risk prediction models. Your patient comes into the office, and she has a great fear that she has an increased risk of breast cancer because somebody in her family had breast cancer, and she needs you to help her sort out what her breast cancer risk is. A nice model that's validated and on the National Cancer Institute's website, we call the Breast Cancer Risk Assessment Tool, or the Gail model. You can download it. There's an app for your phone. And this is really good if there's not a strong family history. So it includes race, ethnicity, age, history of a breast biopsy, age at menarche, parity, and first-degree family history. It's not intended for those with a strong family history or if they've previously had breast cancer or DCIS or LCIS. And here's what you get if you type in the data to help your patient. So let's take two cases. You have a 35-year-old who started menstruating at 10, so early. She hasn't yet been pregnant. She has 2 first-degree relatives with breast cancer. It gives you a 5-year risk of breast cancer and a lifetime risk. So this woman's 5-year risk of breast cancer as predicted by this tool is only 1.1%. You can reassure her that she's not highly likely to get breast cancer in the near future. But her lifetime risk is 33.7%. So you can use that to help counsel her about risk reduction and screening and all of that. Now, you have a 55-year-old who comes in. She started menstruating at 12, a more average age. She had her first pregnancy at 25 on the younger side. She has 1 first-degree relative with breast cancer, and she's had a prior breast biopsy, which probably we're thinking now is really a surrogate for breast density. You have more biopsies if you have dense breasts. Her 5-year risk of developing breast cancer is higher than that 35-year-old. It's 2.7%, still pretty low. But her lifetime risk is lower. It's only 18%. So it's kind of helpful to think about it in both ways. Now, I've told you that that model isn't super great if you have a strong family history. So we have a couple of models that you can use that emphasize family risk. The Tyrer-Cuzick model actually takes genetic and non-genetic risk factors and tries to merge them together. And it also asks about have they taken hormone therapy, if they had benign breast disease. And you can download this online. BRCA Pro is another model that tries to actually take kind of families and estimate what's the risk that there's a gene running in that family. So it's very focused on family risk, and it's also available for downloading for free online. And then, of course, there's testing for BRCA1 and 2. If you find a mutation in the family, you can test other family members and say, yes, you have high risk, or you just have average risk. Okay, so let's get into breast cancer risk reduction. If you've helped a woman establish her risk of developing breast cancer, now you can help counsel her on ways to potentially impact that risk. So we talk about primary prevention in terms of lifestyle modifications, chemo prevention, and prophylactic surgeries for the highest risk patients. And then we talk about secondary prevention, which includes screening and early detection. So with respect to lifestyle factors, again, I'll just show you the impact that obesity, lack of physical activity, and alcohol use can have on breast cancer risk. So again, if we take a high-risk category for obesity of having a BMI greater than 35 versus a reference group with a normal BMI of less than 25, the risk of developing breast cancer in various studies is 1.2 to 1.5, so a 20 to 50% increased risk for being obese. A physical activity, the high-risk group would be that you're inactive, referent group would be regular activity, and the relative risk across studies is 1.25 to 1.7. And then alcohol use, a high-risk group would be an average of 2 drinks every day versus non-drinkers, and the relative risk is 1.5. So these are all things we can counsel our patients on. And physical activity at a young age can impact risk of breast cancer at an older age. So it's never too young to start exercising. Although, interestingly, the impact of overweight and obesity seems to be more weight gain after menopause. So it's not okay to be overweight and obese when you're premenopausal, but it's even more important to try to control weight gain after menopause. So Ann McTiernan, another one of my colleagues at the Fred Hutch here, took a look at the Women's Health Initiative data And she looked at physical activity and then future development of breast cancer in the WHI study. So there were 74,000 women who enrolled in the Women's Health Initiative study who were between 50 and 79, and they filled out these big questionnaires about their risk for cancers and cardiac disease and osteoporosis and all. And so this study looked at what did they say about their physical activity at the time they enrolled in the study, and then who got breast cancer. So what was the impact of physical activity? And they asked them specifically to estimate what they felt their exercise had been at age 18, 35, and 50. So 1,700 some breast cancer cases were diagnosed over the next 4.7 years after enrolling in the study, and they looked at a control group of women who didn't get breast cancer matched with those who did, and they found that regular strenuous physical activity at age 35 had a 14% reduction in breast cancer risk, and the relative risk of 0.86, which was statistically significant, and it was similar at age 18 or 50, but I think it didn't quite meet statistical significance, but similar hazard ratios. Just 1.25 to 2.5 hours per week of brisk walking had an 18% decreased risk of developing breast cancer. But the greatest reduction was seen with those who did the equivalent of greater than 10 hours a week of brisk walking. And then interestingly, Mary Claire King did a study looking at women in New York who already had breast cancer and were found to have BRCA1 or 2 mutations. And again, they looked at, did other risk factors for breast cancer impact these women who already had known BRCA mutations? They asked them about their hormone and reproductive factors and their diet and all. But what she showed in this study was that women who reported that they had been physically active during their life versus those who reported they had been physically inactive had a delayed average onset of their breast cancer. Remember, all these women had breast cancer. A delayed onset of their breast cancer from age 40 to age 50. So maybe, even in a BRCA1 or 2 gene mutation carrier, by having healthy lifestyle, you can push off the development of the breast cancer till a decade later, which is interesting. What about chemo prevention? I'm not sure this is something that a lot of you talk with your patients about, but it's certainly an option, and we have a couple of drugs that are FDA approved for the chemo prevention of breast cancer. The ones that are approved and the ones we have the most data for all target the estrogen receptor in some way, shape, or form. The aromatase inhibitors shut down postmenopausal estrogen production, and so they impact the estrogen receptor in that way. And the selective estrogen receptor modulators, the SERMs, actually bind directly to the estrogen receptor in the nucleus of the breast cell and shut down cell growth and division and compete with estrogen binding. So they can work whether you're pre or postmenopausal. The first prevention study in breast cancer that was reported was the NSABP P01 tamoxifen breast cancer prevention trial. It was a trial of tamoxifen versus placebo for 5 years in women, 13,000 women who were at increased risk for breast cancer. And this study was designed because we saw in women who had breast cancer that took 5 years of tamoxifen to reduce the risk of that breast cancer recurring, that contralateral breast cancers were also reduced. So the study was designed to look at, can we prevent the first breast cancer? The study was stopped early at a mean of 3.5 years of follow-up. They had intended 5 years duration of the therapy because it had met its primary endpoint according to the Data Safety Monitoring Committee, which was a reduction in incidence of breast cancer. And you can see the red is placebo, the yellow is tamoxifen. Invasive breast cancer was reduced by about 50%. Non-invasive breast cancer, ductal carcinoma in situ, was also reduced by about 50%. Fractures were reduced. Tamoxifen is the first cousin of raloxifene, and they're both pro-estrogenic on the bone, so fractures were reduced. Uterine cancer was increased. Tamoxifen is pro-estrogenic on the uterine lining, although its first cousin raloxifene isn't. And then vascular events were increased a bit. Tamoxifen is pro-estrogenic on the thromboembolic events. Mitch Gail, the same guy who designed that breast cancer risk assessment tool for the NCI, took a look and published a nice paper taking all the raw data on the P01 trial and showing the non-breast cancer events that occurred in women based on their age group. And what's important about this is you can see that for the serious negative events associated with tamoxifen, such as increased endometrial cancer, strokes, pulmonary emboli, DVTs, those are really minimally increased. This is an excess events per 10,000 women on tamoxifen. They're really minimal in young women, premenopausal women, very few excess events. But they go up with age when you'd be at more risk for these events. So, the excess negative events are really pretty minimal in a group of women under 50. And of course, the benefit to reducing fractures is also greater if you're older when you're at higher fracture risk. So this can be helpful in talking about risks and benefits of tamoxifen, because they're quite different if you're talking to a 70-year-old than if you're talking to a 40-year-old. This paper was just published this month. It was presented last month at our San Antonio breast cancer meeting. It's another tamoxifen breast cancer prevention trial, but now with really long follow-up, 16-year follow-up. So I'm just giving you the highlights of it. You can find it in Lancet Oncology. This was 7,000 women between 35 and 70 at increased risk for breast cancer, mainly because of family history or because they had a prior biopsy showing atypia or hyperplasia. And they were assigned to 5 years of tamoxifen or placebo. And interestingly, even after the study first reported its short-term follow-up, the majority of patients and their clinicians remain blinded to this day as to what they took. So they took 5 years, and then they went off study drug, and now we have 16 years of follow-up. So here's what's in the paper. Breast cancers overall at 16 years of follow-up, 7% in the tamoxifen group and 9.8% in the control group. Still strongly statistically significant. In the first 10 years, so 5 years on drug, 5 years off drug, it was 4.5 versus 6.3%. But even now, at 10 years, 5 years after they've stopped their tamoxifen and beyond, there is still a statistically significant difference in the rate of breast cancers that are developing. Other cancers are actually not statistically significantly, but maybe numerically increased on tamoxifen. And the cancers that are increased are endometrial cancer and non-melanomatous skin cancers, interestingly, not sure why. That's statistically significant. And then it may be a trend toward lung cancer. Breast cancer deaths are not impacted at all. It's not statistically significantly different, but there's not even a trend toward less deaths due to breast cancer. And then all deaths, again, not statistically significantly different, but not even trending toward benefit for tamoxifen. So, what do we do with that? I mean, the conclusions are that breast cancer incidence is reduced. In tamoxifen, it's mostly ER positive and DCIS and not the ER negative, more aggressive subtype of breast cancer. If anything, there was a non-significant increase in estrogen receptor negative breast cancer. Tamoxifen does offer a long period of benefit after you stop the treatment. The effect was diminished in women who also took menopausal hormone therapy. I never realized it until this last publication. 40% of women in this study took some concurrent hormone therapy. So there was no effect on all-cause or breast cancer-specific mortality. The increased risk of thromboembolic and gynecologic events was really limited to the period while they were on the tamoxifen. There's a discordance between the reduction in breast cancer events and the lack of a reduction and maybe a numerical slight hint of increase in deaths. Is that just chance? Because the deaths aren't statistically significant. Or does tamoxifen really only decrease the good-acting breast cancers and possibly even increase the bad-acting estrogen receptor-negative breast cancers? Or is it all of that? So in the postmenopausal population, when the toxicities are greatest, I've shown you that for tamoxifen, postmenopausal women do have another class of hormonal therapy, the aromatase inhibitors, as an option if they want to consider chemoprevention for breast cancer. And so how do these aromatase inhibitors work? Postmenopausally, when the ovaries aren't really producing estrogen, We do get a little bit of estrogen production indirectly through the adrenals that are producing androstenedione and androgens. And then in females, peripherally in the fat and the liver, in breast tissue, there's an enzyme called aromatase that can convert the androgens to estrogens. So aromatase inhibitors block that. So what you're doing with aromatase inhibitors is depleting every last bit of postmenopausal estrogen. You can imagine what that does to hot flashes and night sweats. But these are very effective drugs in treating breast cancer as well, but they only work if you're postmenopausal. They don't effectively block premenopausal estrogen. So there are 2 trials that were done of aromatase inhibitors versus placebo in women at high risk for breast cancer, looking at using them for prevention. A National Cancer Institute of Canada study with Exemestane, and then an IBIS-2 study, an International Breast Cancer Incidence study that was done in Europe. And both of them showed a reduction in breast cancer incidence for taking the aromatase inhibitor versus placebo. The NCIC Canada study of Exemestane versus placebo had very short follow-up, only 35 months. And most of the women in the study didn't get breast cancer. It was a 0.9 versus 1.9% rate of developing either invasive or in situ breast cancer, but with early follow-up. The IBIS-2 study had a little longer follow-up, 5 years, and the breast cancer incidence was 2% versus 4%. So a 50% reduction in breast cancers, but again, the majority of women didn't develop breast cancer. Interestingly, both studies reported about a 25 to 30% dropout rate in women taking these drugs in this study. These were motivated women with increased breast cancer risk who enrolled in a study, and 25 to 30% dropped out on average at about 10 months after enrolling. And interestingly, the dropout rate wasn't much higher on the aromatase inhibitor arm than it was on the placebo arm. So women who don't have a disease have to be pretty motivated to want to stay on a drug, I guess. But even the placebo arm they dropped off of, so you can't imagine that that was due to toxicity. So there are 2 good breast cancer chemoprevention guidelines I'll refer you to. The American Society of Clinical Oncology, ASCO, has a guideline on chemoprevention of breast cancer. And the U.S. Preventive Services Task Force also has one that they just released in 2013. And they conclude that chemoprevention is an option for women at increased risk of developing breast cancer. 5 years of tamoxifen, raloxifene, exemestane, or anastrozole have all shown reduced breast cancer incidence in large randomized prevention studies. All these drugs have side effects, and no chemoprevention studies have shown a reduction in deaths due to breast cancer, and that's important to counsel our women as well. And they clearly recommend against the routine use of these medications in women who aren't at increased risk of breast cancer. So a third strategy for the primary prevention of breast cancer would be to remove the breasts, or even remove the ovaries, which can have an effect of reducing ovarian cancer and reducing breast cancer. And Angelina Jolie, with her decision for her prophylactic mastectomy after finding out that she was BRCA1 positive, actually really brought this to light. I even was counseling a young BRCA1 mutation carrier who was in college. She really didn't get her risk. She didn't know what that meant. I was seeing her because her father was a friend of a friend, and she didn't know how to process this. And I finally said something like, well, and Angelina Jolie chose this, and you can think about it. And she said, oh, you mean I have what Angelina Jolie had? And all of a sudden, it like went ding, ding, ding in her mind. So it's kind of interesting how that really kind of brought to prominence the discussion about the BRCA1 and 2 genes and risk for breast cancer. So surgical recommendations for women with BRCA1 and 2, a prophylactic mastectomy is an option. It's not an outright recommendation. So it can reduce your breast cancer risk by 90%. We don't remove every last breast cancer cell. Rare breast cancers can still occur, and it's disfiguring, but reconstruction can be good. Prophylactic salpingo-oophorectomy in BRCA1 and 2 mutation carriers, we do an awful job of finding ovarian cancer early. So actually removing the ovaries and the fallopian tubes is recommended for BRCA1 and 2 gene mutation carriers when they're done with childbearing or by age 40. It can reduce ovarian cancer risk by 90 to 95%, but you can still get a rare peritoneal carcinomatosis. It induces surgical menopause, so you have to deal with those risks and the issue of whether you can go on some hormone therapy. And if done premenopausally, studies have shown that it can reduce breast cancer risk by removing estrogen at an early age. And there seems to be more impact on reducing breast cancer risk in BRCA2 positive patients because BRCA2 breast cancers are more likely to be estrogen receptor positive. At the Seattle Cancer Care Alliance, we have a couple options for you to refer your patients to. If you think that the patient warrants a real full discussion about what her risk is and what her options might be, we just created a clinic called the Reduce Your Risk Clinic, which is for patients whose risk is primarily non-genetic. So those who have had a biopsy with atypia, or they've had ductal carcinoma in situ, or they have high mammographic density, or they've had radiation to the chest. And then we have our breast and ovarian cancer prevention clinic, which is for those who have more of a genetic risk. It's multidisciplinary with medical genetics, medical oncology, and gynecologic oncology participating. So I'll end with some discussion of screening and early detection because that really is secondary prevention of breast cancer. Finding cancer early can reduce morbidity and mortality of the cancer. You all know that there's a lot of controversy about screening for breast cancer. We have multiple imaging techniques that have been developed for identifying breast cancer early. Mammography is the most proven, has the most evidence of benefit in screening. Ultrasound is mainly used as a part of a diagnostic workup after an abnormality is found on physical exam or on mammography. And then MRI is used in screening in high-risk patients. There are potential benefits of screening mammography and potential harms. The benefits are that randomized clinical trials have shown a 15 to 20% relative reduction in mortality due to breast cancer. The absolute benefit is greater if you start at 50 than if you start at 40. And there are potential harms. There's the harm of overdiagnosis and overtreatment. Finding cancers, particularly ductal carcinoma in situ, or very low-grade invasive cancers that never would have caused a problem, never would have evolved or spread or led to a problem, particularly in an older population. You have false positives from imaging, callbacks. You need other views on mammogram or potential biopsy. And about 10% of women are recalled after a screening exam for further tests, but only 5% will actually have cancer. And then there are also false negatives. You have a normal mammogram, and the woman thinks she doesn't have a risk of cancer, so she kind of rides off, ignores that lump that she felt because she just had a normal mammogram. So we've got issues there, too. The American Cancer Society recommends still mammography annually beginning at 40 and continuing as long as a woman is in good health. A clinical breast exam about every 3 years until you're 40, then annually. Self-exam is an option because we've never had a randomized study showing that it helped women in reducing breast cancer deaths. So we now say breast self-awareness, which could include learning how to do a good self-exam. And then MRI for women with a high lifetime risk of breast cancer. In 2009, the U.S. Preventative Services Task Force kind of reversed their prior statement on screening and said for 40 to 49, they don't recommend screening routinely. You should individualize the decision to begin biennial screening according to the patient's context and values. That's really hard to do. Age 50 to 74, they actually recommend screening, but they say every 2 years because biennial exams preserve most of the benefit of annual mammography, and they cut the harms in half because you're doing mammograms half as often, and so you have less callbacks and less biopsies. And over 75, they just don't even make a recommendation. They say there's no insufficient evidence for clinical breast exam, and they actually recommend against teaching self-exam. Now, this topic, if you go on the website here that I've given you, actually is in the process of being updated. I was hoping that by the time this Grand Rounds came around that they might have the updated guideline because they've been working on it for a couple of years and we're expecting it imminently, and so we'll see what it shows. This is data that was used. It was commissioned by the U.S. Preventative Services Task Force to try to make a statement about what kind of age to start and what kind of interval. Here's what they chose based on modeling studies, biennial between 50 and 74, and this is the mortality reduction that would be predicted. Here's annual between 40 and 84, which you see really has almost double the mortality reduction, but because you have so many more mammograms, you also have a lot more harms. So this is what U.S. Preventative Services Task Force shows. The age to start, I don't think there's anything majorly different between the 40 to 49, 45 to 49 and the 50 to 54, but we've kind of picked this arbitrary cutoff between 49 and 50. So what age to start screening? This is just population stuff. You're going to have to talk about your patient with a risk, about a risk. And then I'll just talk about mammographic density here because this is something you're going to hear more and more about. So 21 U.S. states now mandate the reporting to women that they have high breast density on their mammogram. To both the patient, they need to get a letter, and the primary provider, the person who's ordering the test. Washington has proposed legislation pending, and there's national legislation pending. So breast density is all the ratio of fibroglandular densities versus the fat in the breast. Here's the proposed legislation sitting in front of our legislator right now, that women will get a notification if they have high breast density that your mammogram shows your breast tissue is dense. Dense breast tissue is common, but it can make it harder to evaluate the results of your mammogram. Adult women of all ages are encouraged to perform a monthly breast self-exam. I don't know where that came from. This information about your mammogram results is given to you to raise your awareness and to inform your conversations with your primary care providers, who know nothing about how to talk to you about this, by the way. A report of your results was sent to your primary care provider. I don't know if this is the final wording, but here's what you need to know. And this is a great website. This is the California Breast Density Information Group, www.breastdensity.info. So what they're showing us here is that 50% of women undergoing screening mammography are classified as having either heterogeneously dense or extremely dense breasts. So half of your patients are going to get this notice. But only 10% are extremely dense. There are two implications. One is dense breasts increase your breast cancer risk. But mostly if you're in that 10% who have extremely dense breasts, the relative risk is 2, versus heterogeneously dense where the relative risk is only 1.2. Probably the most important thing is that the sensitivity of mammography is reduced, and it decreases by 10 to 20% for women with dense breasts. 4 of the states that have breast density legislation also mandate insurance to cover additional testing, but they don't say what. The California Breast Density Group says you shouldn't replace mammography. It's still the only screening modality that's been shown in randomized clinical trials to reduce breast cancer mortality. And if a patient has dense breast, this would be a good opportunity to do a general breast cancer risk assessment with her. And that there are some other options such as MRI, ultrasound, and 3D tomosynthesis. So here's a publication that's still EPUB ahead of print, talking about adding ultrasound to women who on mammography have a dense breast. And this is all modeling, okay? And it suggests that adding an ultrasound after a woman has a normal mammogram and has a dense breast would avert 0.36 deaths, but add an additional 354 biopsy recommendations per 1,000 women. So not very cost effective. And yet 3D tomosynthesis, which is really CT scan merged with mammography, might be more beneficial. And this is where we're going with mammography. Our mobile mammovan in one of our machines is now 3D tomo. It's basically, you still have to squish the breast, but it moves around the breast, and you get these thin reconstructed slices instead of just 2 views. And in a study of digital mammography versus digital mammography plus tomosynthesis, we see that what tomosynthesis can do is it can be slightly more sensitive at picking up a cancer if it's there, but actually most of its benefit might be that it actually reduces the false positive rate by doing thin slices, and you can see a funny thing on a mammogram a little bit easier, and you actually would lead to less biopsies. So Christoph Lee, who's in our breast imaging group, just first authored this, again, modeling study on what would adding 3D tomo to digital mammography do for women with dense breasts. And this is also EPUB ahead of print. And they estimated that 0.5 deaths would be averted, but 405 false positive findings would be avoided, not added, by adding 3D Tomo to women with dense breasts in 1,000 women who have 12 rounds of screening. So this, they're saying, could be cost effective. And this is probably where we're going. We are going to replace all of our digital mammography machines with 3D Tomo by the end of the year. It's in our budget for this year. And this is an ongoing trial that you might want to refer your patients to if they have increased risk of breast cancer and they have dense breasts. It's called the STAR trial, Screening Tomo and Automated Breast Ultrasound Study. And it will, with a woman's coming in for a mammogram anyway, and she will get research breast tomo for free and an automated breast ultrasound, which captures ultrasound everywhere in both breasts digitally as well. So I had a couple of other things. I had an MRI that I don't have time to go over, and recommendations for BRCA1 and 2 mutation carriers are just start earlier and generally add MRI. And then for ovarian cancer, there's no evidence behind any of this, but do transvaginal ultrasounds and serum CA125 markers. And I'll leave you with the message that we can help our patients reduce their risk of breast cancer, or at least better understand their risk. So we should encourage our patients to take charge of the factors over which they do have control. We can help them with risk evaluation and genetic testing if appropriate, counsel them on menopausal hormones, weight, physical activity, alcohol use, and breast cancer screening. So we can empower our patients to take charge over the things they can control. And this is Team Survivor Northwest, which is an exercise and fitness program that we founded in 1995 for women who already had breast cancer to get out there and be physically active. This is their dragon boating group. So thanks for your time. I'd be happy to take questions up front.